So thank you, and good evening in India, but different time zones. So welcome for this AeHIN webinar, and we are grateful to the organizers for providing us opportunity to talk to you about the Public Health Foundation of India and our work, particularly focusing on health information systems and our engagement in that context. So we are grateful to you for this opportunity. I will briefly deliberate on as a portfolio of Public Health Foundation of India, and then we'll deliberate on the work that we have been undertaking. Most of our work is in close collaboration with the World Health Organization, will be presented by Dr. Preeti and Anjali. Public Health Foundation of India was established in March 2006 with a mandate to build Indian institutes of public health in India. And the model that we have adopted is truly a partnership for public purpose, where we have a strong representation of the government, academia, civil society organizations, and industry leaders on the board of the PHFI. We are uniquely positioned as a public-private partnership to deliver impact in healthcare systems. And as mentioned, that we have been closely working and we have a strong representation of national and state governments, academia, research institution, corporate and industry leaders, healthcare professionals, communities and NGOs, and international organizations. And our DNA truly reflects the transdisciplinary learning and multisectoral applications in the context of public health. If we can see the Board of Public Health Foundation of India, which we call as an executive committee of PHFI, as a representation from the government of India. We have industry allies like Dr. Rati Godrej and Mr. Atul Nishar. We have former member Dr. Muzaffar Ahmed, National Disaster Management Authority. We have Madam Vandana Shroff, the partner Cyril Amachan Mangaldas. We have Lieutenant General M.D. Venkatesh, Vice Chancellor of the Manipal University. Mr. Ranganathan Natarajan is a co-founder of Foundation Partners. Dr. K.P. Krishna is the former Secretary Government of India. Dr. Girija Vaidyanathan is the former Chief Secretary Government of Tamil Nadu. Then we have Atul Nishar, who represents the Hexavet Technologies Limited. We have Lieutenant General Madhuri Kanitkar, Mr. Srinivas Raju Garu, and then Professor Reddy, who was earlier the president of PHFI on the board of PHFI, and Mr. Ramadurai, the former vice chairman of TCS, is the chair of the board of PHFI, and as a president, I also sit on the board of the PHFI. Our vision is to strengthen India's public health institutional and systems capability and provide knowledge to achieve better health outcomes for all. And how do we do that? By establishing Indian Institutes of Public Health. We have established 5 Indian Institutes of Public Health, developing the public health workforce and setting standards, and advancing public health research and technology, and finally strengthening knowledge application and evidence-informed public health practice and policy. Our portfolio includes education, where we offer doctoral programs, master's level programs like Masters in Public Health, Masters in Clinical Research, Masters in Health Informatics, Masters in Hospital Management. We also offer postgraduate diploma programs and short-term courses, but focus is also on e-learning programs ranging from health promotion to health systems related programs, and programs like monitoring and evaluation to HIV/AIDS, to GIS applications in public health, to public health nutrition. So a variety of the areas that we are engaged and offering programs as e-learning programs. We and our faculty are involved and engaged into program and policy relevant research. We do conduct short-term training programs, but also training of primary care physicians, engaged in capacity building initiatives in the context of policymakers and media. Also, we undertake advocacy in public health on major public health issues. We are also involved and engaged in affordable technologies for primary care. We support the policy making and provide technical assistance to the central and state government. We work in a variety of public health areas, from mental health to violence against women, to environmental health, to infectious diseases, non-communicable diseases, to sanitation, to injuries, health systems, disabilities, public health nutrition, social determinants of health, maternal and child health. These are the broad areas that we are currently engaged into. And as I mentioned earlier, that we across these four pillars of activities that we offer on-campus academic programs. We also offer programs in the mode of digital learning, conduct professional trainings, then research and technical support, and health systems innovations are the four pillars of our engagement into the public health. Since 2006, you can see that we have been driven measurable impact across India's healthcare ecosystem, across training, research, and partnerships. In India, we are engaged with 25 state and central government supported initiatives, high impact research publications, more than 4,000. We have trained close to 19,000 public health professionals in short courses. 2,700 public health professionals are educated in postgraduate diploma and master's level programs through our on-campus programs. We have several partnerships with both national and international institutions. We offer 30 plus certificate courses on primary care physicians. Close to 39,000 primary care physicians are trained in different aspects of the primary care, and close to 10,000 now professionals are trained through our e-learning programs. We have presence in five places in India, and we have built Indian Institutes of Public Health at these 5 institutions. And we also have a center in Bangalore we call as an ancillary center. As I mentioned, these are the 5 institutions that we have. IIPH Delhi is based in Gurugram in Delhi. It's the national capital of India. We have an institute in western part of the country in Gandhinagar that's called as IIPH Gandhinagar. It's an independent university in Gujarat, which is on the west coast of the India. On East Coast, we have institute in IIPH Bhubaneswar, and extreme Northeast, we have institute in Meghalaya. It's called as IIPH Shillong. And in Southern India, we have institute in Hyderabad, in Telangana as a state, IIPH Hyderabad. And we also have ancillary center in Bangalore, which we offer some programs through at Bangalore Center. Through these institutions, we offer long-term academic programs. We conduct training programs, we offer e-learning programs, do research, and also provide technical assistance to the state government. Our vision is to have world-class public health institutions responding to the public health challenges in India through a widespread presence across the country, and we want it to be nationally transformative and globally acclaimed. This is the first campus that came up. It's an IIPH Gandhinagar in Gujarat, which is an independent university now. This is the second campus that we have in IIP Hyderabad. Is an academic block, was recently inaugurated, and we offer variety of on-campus programs to this campus. We are aiding policy development and undertake review in multiple areas of environmental health, to health literacy, to universal health coverage, to review of programs like polio and National Health Mission. We're engaged in non-communicable diseases and mental health and immunization. So in a broad spectrum areas of public health, our engagement is both at the policy level and implementation level is being there. Research is a very important portfolio at Public Health Foundation of India, and we have been developing research leaders and establishing research consortiums. We have international co-mentored PhD, 43 in number. We have Department of Biotechnology Wellcome Trust India Alliance Fellowship to 15 of our colleagues. Then we have the Science and Engineering Research Board fellowships to 36 professionals. DST, that's the Department of Science Technology Fellowships, Women Scientist Fellowships. Similarly, we also have international fellowships such as Poverty Fellowships, DBT Wellcome Trust India Alliance Center Grant, and DBT Wellcome Trust India Alliance Team Science Grants. We have competitively earned many grants across the time period. Till recently, we have close to 17 100 crores in INR awarded as research grants to the PHFI. We have set up 5 centers of excellence, and we also have a Fogarty International Center for Training and Research, and we are recognized as a scientific research organization by Ministry of Science and Technology. Our research has actually contributed to achieving some high rankings also, like Schemago institutional ranking in 2020. In the health category, we are positioned first research ranking, second in societal ranking, and 10th innovation ranking in India. Similarly, in Schemago institutional ranking in 2021, also we stood first in the overall research category and second in the health sector category. And 16 of our researchers have been recently listed by the Stanford University in the ranking of the world scientists across the globe. We have been also awarded Clarivate India Research Excellence Citation Award in 2021 in the medical and health sciences category, which is a testimony of our research engagements. We have received several awards and recognitions for our training programs from variety of the institutions and organizations and agencies. And these are some of the, again, awards and recognitions which are earned by our training programs, academic programs, and by our faculty over a period of time. The PHFI's guiding principles is that we believe that knowledge needs to be translated into action, which can ultimately would have an impact, and equity should be focused when you actually advance the public health agenda. We believe that science is sterile if it lacks the social relevance, and policies would crumble and cliff it if they are not firmly placed on a pedestal of valid science. And therefore, we firmly believe that as knowledge generation is critical, but knowledge translation is much more critical. During COVID-19 times, PHFI has provided leadership to several initiatives in the country. We partnered with several NGOs. We conducted research in a very short amount of time during the COVID-19. Then we conducted trainings for primary care physicians and frontline health workers. We also sat on global technical panels and commissions. We engaged ourselves in health communication through multiple media for generating awareness and providing information to the populations. And within the country also, several of our colleagues participated various technical committees, both at the state level and at the Government of India level during the COVID times. And we contributed quite significantly in that context. And our contributions, both engagement with the state governments and union government, are recognized nationally and internationally. And variety of the areas and engagement, particularly in the context of health systems, we have been contributing. And my colleagues, Dr. Preeti Negandhi and Anjali Sharma, will deliberate on our engagement in the context of the health information systems. So thank you so much for this opportunity. I will now request Dr. Preeti Negandhi to deliberate on our engagements on RIH.
Yes, thank you, Professor Zolpe. Thank you and good evening, everyone. Professor Zolpe has given an overview of what PHFI does, and I am going to give you an overview of our engagements in the context of health information systems. Our work in the area of health information systems has been going on since around 2014. We started very small with an assessment of the PRISM tool in one of the northern states of India, Uttarakhand. India, is a big country with 36 states and union territories with more than 600 districts. So it's sort of a land, a gold mine for data. But the problem that had been observed is that we do not have enough capacity to analyze that data or to interpret the data or even use that data. So one of the very early on activities that PHFI did in partnership with Measure Evaluation was to study the RHIS performance specifically in the context of better data quality and continuous use of information in certain select health facilities of the state of Uttarakhand. And we used the existing PRISM tools for this assessment because this is what we understood as, a sort of a metric for understanding RHIS performance across these health facilities if we wanted to understand how data is being used for better health outcomes. This assessment was carried out in 2014, and then a similar exercise was also done around 2 years later in 2016 in another northern state of India, Punjab, where we wanted to revise the PRISM tool So the tool was revised, certain additional components were added to the tool. We piloted that revised tool in Punjab, and then the lessons that we learned from that exercise were documented to be used as guidelines to revise the PRISM tool further. Another activity that we have done, and this is something that we have sort of built upon over the years, is to be engaged with the state government of Haryana for data usage workshops. There was a request which came in from the health department of the state government of Haryana around 2014-15, wherein they wanted the capacity building of their health officials from within the public health system across all the districts of Haryana. Haryana is where we are based, Indian Institute of Public Health Delhi is based, and they wanted their health officials to understand the use of routine health data. They have around 15 or 16 portals within the health department, which, as you can imagine, the amount of data that is being generated is humongous. But the capacity of the health officials to actually use that data for better health understanding, for better service delivery was very limited. And they wanted to leverage our expertise in this area to provide that sort of capacity building for the health officials. So we did multiple rounds of these workshops for the different district health officials, and this was done around 2014-15. This work was supported by WHO headquarters and, of course, the state government of Haryana. We also partnered with AeHIN earlier in around 2015-16 to launch a new South and Southeast Asian RHS Network, wherein we partnered with WHO CRO, and we also received technical support of measure evaluation. The idea was to create a RHIS strengthening subgroup as part of the AeHIN network. And the main focus of this activity was to strengthen governments to work with routine information, primarily around the area of health programs, health planning, management, monitoring, implementation, and of course, later on, policy making as well. As part of this activity, this was a very small short-term exercise wherein a regional database was developed for inclusion of certain potential AeHIN countries. A concept note for this RHIS network was drafted, and the founding session for the launch of this network was presented. One of our big ticket exercises that we undertook along with WHO, CRO, Measure Evaluation, JSI, and many other global partners was piloting the RHIS basic concepts and practice curriculum. PHFI was instrumental in designing and developing the curriculum along with these other partners. We were a global team of experts, and a lot of work went into developing this curriculum. And eventually, it culminated into the pilot testing of this curriculum over a comprehensive 2 weeks. This workshop was actually conducted within our premises at IIP Delhi in June 2016. We had participants coming in from Myanmar, Nepal, Bangladesh, India, of course, and we had representation from Ghana as well. And the aim of this workshop or this pilot was to enhance the capacity of these participants in everything that you can possibly do with RHIS, right? From conceptualizing, designing, developing, governing, and of course, use of this information that is generated through the system so as to be able to improve public health practice and service delivery. We had Theo from GSI, who was working with GSI at that time, who helped us and sort of mentored us through the entire process of piloting this curriculum. And of course, there were others from WHO and Measure Evaluation as well, who helped us in the process. After this pilot, the successful pilot of 2 weeks, this RHIS curriculum was harmonized for global use. And it has ever since been used by us, and I'm sure by many others, for capacity building initiatives. It's up on the Measure Evaluation website. It's in the public domain. In fact, we didn't stop at this pilot. We ourselves adapted the curriculum as a part of a module for the health systems track for our MPH students at our institute. After this pilot had been, after this curriculum had been harmonized and it was available for use, we conducted multiple workshops across the region. Now, we had moved from beyond India to the Southeast Asia region. In 2018, we conducted a country-specific workshop in Maldives, especially for the officials working in the HIS division in Maldives. Then COVID struck, and we could not do in-person workshops, but WHO CRO supported us for conducting 2 virtual regional workshops for the HIS officials of Ministry of Health across the different Southeast Asia countries. So we did 2 such workshops, one in 2021 and one in 2022. And we've also sort of adapted this workshop curriculum, the entire material, to incorporate this into our own workshop series. So at IIPH Delhi, we announce this workshop once a year, and we have participants from within India, even outside India, participating in this workshop. Besides the RHIS Basic Concepts and Practice workshop, we've also dabbled in workshops around routine data quality assessment. This was a tool that was developed along with measure evaluation and GSI. And this workshop was conducted in Nepal in 2016, wherein they wanted to use the tool, understand the tool, and then use it for monitoring the quality of their data from across the various information systems that they had been using at that point of time. We've worked with AeHIN in the past, where one of the activities we did was to provide Secretariat support for the AeHIN RHIS focus group activity to implement the focus group's action plan. And the activities as part of this Secretariat work were to catalyze the activities for 3 main RHIS themes. And I think that's around the mandate of the AeHIN group, which is capacity building, advocacy, and knowledge management. This is for not just the Southeast Asia region, but also for other countries within the AeHIN group. As a result of this activity, a core team of RHIS experts was formed with 14 countries representing the group, and we had 1 to 2 members from each of these 14 countries. Subsequently, a generic advocacy statement for RHIS strengthening was drafted, and of course, as like many other activities, this was also a short-term activity, but I think we need to start off from where we had, we had completed this part of the activity, and maybe we can see how we can take this forward. Some of our other big ticket HIS contributions have been the Score for Health data package. This work we had done in 2018, just before COVID, wherein a very comprehensive assessment of the scope package, the technical package, was done for all 11 member countries within the CRO region. And again, this was supported by WHO CRO office. This is basically a technical package of all the essential HIS interventions, actions, tools, resources, and for the countries to understand where they lack in HIS, where they are mature enough to understand their HIS, their capacities with respect to analysis or interpretation or use of HIS. It was a humongous exercise. Anjali will be talking more about that in detail in terms of the methods, the results, etc. We've even published a paper related to this. Anjali will talk more about that in her talk. Once the score activity was over, we went on to actually get into sort of phase 2 of this, where we specifically looked at the indicators around sexual, reproductive, maternal, neonatal child health, violence against women, and healthy aging, again for the 11 member countries of the CRO region. A very similar activity to what we did for SCORE, but here it was more to do with the indicators only for these 3 domains. We worked with the 11 countries for more than 300 indicators. So again, this was a very comprehensive exercise where we had to track the current status of each of the 11 countries for each of those 300 indicators. And again, Anjali will be talking more about that in her presentation. Another activity that we have very recently been doing with WHO India office this time is to develop the health equity profile for India and 5 states within India. So we are using the most recent survey data that's available to come up with an equity profile and to understand, across various stratifiers, where we are with respect to various domains of health, communicable diseases, non-communicable diseases, nutrition, maybe some WASH indicators, etc., etc. And again, Anjali will talk more about this in detail during her presentation. Very recently, we have been part of the Health Data Collaborative, which is a joint effort by multiple global health partners. And the area of work that HDC does is to work with countries to improve the availability, quality, and use of data for local decision making. And to track health-related SDG progress. PHFI has been a member of this Health Data Collaborative, primarily part of the RHS working group. We have been recognized as a regional institute, especially for the CRO region, but also beyond that. And we are also part of the research academies and the technical network within the collaborative. This is a more recent addition to our portfolio in HIS. These are some of our publications, and they are available in the public domain. Thank you very much. Anjali, over to you.
Thank you, ma'am. I'll just share my screen. Yeah, so the first project I'll talk about is WHO's Score for Health Data Technical Package. Dr. PT just kind of briefed you about it in her talk. So basically, this package was developed by WHOs and partners to assist countries in strengthening country data systems and capacity to monitor progress towards their health-related SDGs and other national and subnational health priorities. So this framework forms the cornerstones of WHO's efforts to strengthen health information systems worldwide and also support countries to generate, analyze, report, and use health data. So basically, SCORE is an assessment of a country's data systems and bring forth a paradigm to invest in health information systems. So the SCORE package brings together for the very first time a set of 5 essential interventions, each of which include recommended actions, tools, and resources to support countries to tackle their data deficiencies, identify gaps, and guide investments. And it can also help prioritize specific HIS areas for deep dives for countries. So what exactly is SCORE, if you may ask? It's an acronym where S stands for Survey Population and Health Risks, count births, deaths, and causes of death, optimize health service data, review progress and performance, and enable data use for policy and action. So if you'll observe more closely, the first 3 interventions, which are S, C, and O, they focus more on improving critical data sources and their availability and quality, while the remaining interventions, which are R and E, they focus on data management and use. That is data synthesis, analysis, access, and use of health data for action. Now, if you'll allow me to elaborate a bit on these 5 key interventions, we also had elements and indicators. So for every element, there was a set of simple, verifiable, and standardized score indicators that can help identify critical gaps and needs of a country and allow for continuous monitoring. So we had an assessment tool and a questionnaire, which was developed by the WHO CRO office, WHO headquarters, which tracked various indicators under each element. So for example, speaking of intervention S, we checked, does the country has a system of conducting regular population-based health surveys and track health trends? How is a country based in terms of its capacity to detect public health threats? Do they have regular census every 10 years along with a post-enumeration survey? Next intervention is S. And we all agree and know that all countries should have a well-functioning CRVS system that registers all births and deaths, issues birth and death certificates, and compiles and disseminates vital statistics, including causes of death data. So we looked at data for countries with respect to the C component in terms of their completeness of birth and death registration. Also, were they classifying their causes of death data systematically or not? Next intervention was optimize health service data to ensure equitable and quality services for all. So this intervention focused more on monitoring quality of care. We looked at data generated from all levels of healthcare, including the primary care. So the elements focused on routine facility and community reporting systems, as well as health facility survey. In this component, we also looked at indicators related to the national health expenditures and health workforce density. The next intervention is review progress and performance of the health sector to make informed decisions. So here we had elements to review a country's progress in terms of its progress in delivering sustainable development goals. So the indicators in this intervention focused on whether the data which is collected and collated, is that data being actually used to improve health sector performance and address challenges, whether a country is regularly monitoring the progress and performance of their national health sector strategic plan, are they assessing their indicators progress against targets that they have set out in their analytical reviews, Also, do they actually use multiple data sources apart from the periodic population-based surveys? Do they also include RHIS data for their analysis and also putting that into strategic planning and operations? Are these reviews of good quality? And also, do they have disaggregated data in terms of their socioeconomic status, gender, and also subnational units like districts, or it can be counties depending on the country's system. The last intervention is enable data use for policy and action to accelerate improvement in health. Here, the indicators focus more on promoting data governance and access, because the data needs to be accessible and it needs to be credible, it needs to be of good quality and derived from multiple sources for sound decision making to improve public health. So all in all, this package is fundamentally, it's a score to reach your country's health goals. So this tool can help identify existing gaps in country's health data and also establish health priorities and guide investment in health information system. So moving on to the process. So the SCORE global assessment started in the year 2018, and the data that we had to review was decided to be for the last 5 years, that is from 2013 till 2018. The global assessment covered around 133 countries' health information systems, which is about 87% of the global population. Now let's shift our focus to the CRO region. WHO CRO entered into agreement with PHFI somewhere in August 2018, and that's how we came on board for this activity as consultants for data collection and review and for mapping the HIS capacity of all the 11 countries. So PHFI team comprising of Professor Zotpe, Dr. Preeti, and me, we conducted a comprehensive assessment of all the SCORE package for all the 11 member countries, with of course the oversight and guidance being provided from the WHO CRO team. So this evaluation also involved a systematic and iterative desk review and analysis of the relevant HIS documents which were available with the countries at their national and subnational levels. So let me walk you through a bit for the key steps that were followed for populating the tool and assessing a country health information systems. So the first step was preliminary tool testing and preliminary desk review. PHFI team began with the initial desk review to fill out the assessment tool, which was shared to us from the WHO headquarters. And we also did the initial pre-testing of the tool in one SEER country. Dr. Preeti actually visited to Kathmandu, Nepal to do the pre-testing of the tool, which was, of course, facilitated by the WHO CRO team. They connected us with their counterparts in Nepal. And we also started with the initial desk review for all the 11 countries. The next step was the technical consultation that was held at WHO headquarters in Geneva in the second week of September 2018. So here we presented results from the initial desk review that were emerging for all the 11 countries. And we also had to present results for the pre-testing of the tool that was done in Nepal. The participants were also asked for their feedback and recommendations, and also flag some issues on the then version of the tool. Post the consultation, we gained a lot of clarity in terms of the indicators, their data sources, and also our scope of work. And we continued with the desk review and analyzed both published and gray literature as source material for each country to populate the tool. And additionally, we also cross-reference country data with the information from the global databases, such as the health workforce, health expenditures, to ensure a comprehensive triangulation of data. Now, following this was the review and preliminary validation. Now, by this time, we had the first thorough cut of the populated matrices for all the 11 countries. And we shared these findings from the desk review with the country representatives in the regional conference, in the regional consultation that was held in Colombo, Sri Lanka. We wanted to gather their feedback on the tool that we had populated at our end. And we shared the country matrix with the respective country representatives. And we also gave them a timeline for their review. Apart from this was a 2 or 3 day whole day consultation. This consultation also actually gave us the opportunity to ask the country representatives for any missing source documents. which were under review at the country's end, or they might not have been published and they were not available in the public domain, because having the source documents was a mandatory step while filling out the tool. For every response in the tool, we had to supplement it either with a URL or uploading the source document as an evidence that yes, that indicator is being tracked, there is a system in place. And if a source document or a URL was not available, then it could bring a country's score down for that particular score indicator. So after the consultation, after the consultation, the country's HIS focal points, they reverted to us with their reviews, edits, and feedback. And the PHFI team again re-looked at the drafts that they had shared to finalize the results. And then these final drafts and findings were then again shared with the respective countries for additional validation, a final review, their endorsements, and sign-off. So once we had their sign-off, we shared the final data of all the 11 countries along with their URLs and the source documents with the WHO CRO team and WHO headquarters for further analysis at their end. By this entire activity was kind of finished by March 2019. And then following the global analysis, WHO released their first report in February 2021, which clearly highlighted the urgent need for better data to improve health outcomes. And it also mentioned that rather all countries have the potential to realize there's a very stronger data system. So not even a single country was kind of mature and had sustainable capacity in terms of all the intervention and elements. Now I'll very briefly mention about the WHO scoring criteria. So remember I mentioned about every element had a set of indicators for different criteria. So those indicators capacity were kind of scaled on a 5-point scale, weighted by their importance in the overall health information system. And then the indicator score was combined to give a total indicator score for that element. So for example, let's talk about the first indicator, which is the system of electronic capture of patient level health data in primary healthcare facilities, which is standardized and fully operable with the aggregated routine health information system. So if a country had less than 10% facilities who were following this kind of a system, then that country would be under nascent capacity. If the countries had around 10 to 40% facilities who had an electronic system to capture the patient level data at the primary care level, then that country would be of limited capacity. If the system was partially there, then the country's capacity would be moderate. And if all the facilities had a very systematic system for electronically capturing the patient level data at the primary care health facilities, which is fully interoperable and standardized, then that country would fall under the sustainable capacity for that particular indicator. Now, moving on to the results of the score assessment for the Southeast Asia region, countries showed varying level of capacity in different health data interventions. The strongest capacity emerged in serving population and health risks, which is the S intervention, particularly for census and health security data. However, intervention S, which is the vital statistics and causes of death data, has limited development, with most countries having either nascent or no capacity on causes of death data. In terms of the O intervention, no SEER capacity had kind of achieved sustainable capacity in fully optimizing their health service data. And also, although some indicators may be available and accessible at the national level, reporting data at the subnational level and disaggregated by gender and age remains challenging. And this can sometimes be a hurdle for countries to actually monitor their progress towards the universal health coverage. Now, taking a closer look at intervention O, I want to draw your attention to the first part. The countries are at different stages of capacity with respect to the systems that support the availability of routine health service data. Except for the 4 countries, most have moderate or lower capacity for functional reporting system. Half of the countries did have an institutionalized system of data quality assurance for all health facilities. But the remaining countries did not have such system, and it can obviously raise a question whether or not the data is actually available on primary care, whether that data is robust enough to confidently inform decisions. which brings me to actually highlight a very pertinent point that we need a change in data culture, demand and use. There is a definite need to catalyze a cultural shift as the health workers' use of health data at all levels actually increases the demand for quality routine data. Next slide. Now, shifting the focus to intervention R, except for three countries, there was limited institutional capacity for data analysis, especially at the subnational level. And there was also very limited engagement that we found in the CRO region for national public health and academic institutions in actually providing such analysis. And although half of the countries, they did have a well-developed capacity to conduct regular analytical progress and performance reviews, with most countries publishing their analytical reviews quite regularly. But most of the reviews, they did not have adequate equity measures, like, in terms of socioeconomic and gender, and also the comparative analysis, which was one of the indicators under intervention R, that is comparison with similar countries, that was missing. So if I'll sum it up, we need to improve data quality analysis and use for better evidence-based policy and planning. We also face some challenges along the journey, especially during data collection and assessment. So with regards to the language barriers, so some of the source documents that were provided by the country, they were in their local language, and it was kind of difficult for us to review and validate at our end. So in those times, we would actually maybe take the help of Google Translator, or we would directly connect with the country counterparts to translate that particular text for us. There were delays in data collection and validation owing to lack of responses from certain countries, despite multiple follow-ups. So we kind of struggled to meet the timelines during those times. And we also found that in terms of data collection, there was more data in the public domain and with the countries for interventions S, C, and R, and there was less data for interventions O and E. So those of you who wish to know more about SCORE and your own country's assessment can visit these links at your convenience. Now, drawing upon our experience and the work that we did with SCORE, we replicated and adapted similar techniques for the second HIS project that Dr. Preeti just mentioned in her presentation. This work we did with WHO CRO, but this time the focus areas were more specific. The data sets and indicators were related to SRM and CAH, violence against women, and healthy aging. The aim was to develop a regional monitoring framework for these three domains and also for some other technical units, by identifying a set of indicators that are essential to be tracked if we want to improve the situation of a particular country for these three domains. So to start with, the first step was a comprehensive online desk review. We looked for indicators in the CR regions which were being tracked with respect to these four domains. The major data sources that the team looked at for these indicators were health-related sustainable development goals, UHCs, WHO's 100 core global indicators, ENAP indicators, which is every newborn action plan, global strategy document, quality, equity, dignity indicators, which is produced from the Network for Improving Quality of Care for Maternal, Newborn, Child Health, ending preventable maternal mortality, which is EPMM indicators. We also looked at WHO safe abortion indicators. We looked at RMN, CH country profiles, and also a list was shared from the WHO CRO team for us to look at and review and finalize the indicators. The matrix that we actually prepared initially, it also had other elements in terms of we wanted to look at the global definitions for all these indicators. We also wanted to know the status of tracking of each indicator, whether it is being done through periodic survey like DHS or MICS, or it's also the data for those indicators is also being collected through RHS, or both, and whether the definition which is used by the country to track the particular indicator is same as a global definition or is it different. We also look at the disaggregated data. We wanted to know if it is available for stratifiers like age, mother's education, residence, and wealth. So that's how we arrived at the master list of indicators to be tracked, and the total indicators was somewhere around 330 plus across the 4 domains. After kind of finalizing our matrix, we started with populating the tool, and then the populated tools were shared with the countries' focal points for their review and edits. The next step was conducting virtual meetings, because this work was undertaken right in the middle of COVID pandemic. So we had to rely on Zoom and other virtual platforms for us to connect with the country representatives. So we kind of explained the objectives of this exercise. We also took the opportunity to kind of ask the team to, if they have any doubts or they had while filling the tool, or if they want to kind of edit some information. So once the countries reverted to us with the revised populated drafts, we reviewed and we shared the final analysis with the WHO CRO office. Towards the last leg of the project, we also undertook a comprehensive SWOT analysis to understand a country's health weaknesses, their actionable opportunities and threats, if they have any with regards to collection and compilation and use of data and indicators related to the 3 domains. Now, apologies for a bit of a crowded slide, but just in the interest of time, I want to quickly highlight some findings. So for the SRM and CH domain, the core health indicators of global and regional importance are primarily tracked through periodic surveys. Some additional are also being tracked through the RHS survey. And these indicators are maternal rates, ratios, indicators related to antenatal care, intrapartum and postpartum care, contraceptive prevalence rate, adolescent birth rate, adolescent mortality rate, UHC coverage index, cervical cancer screening. However, across the region, we found that there were discrepancy in the RHIS indicator definitions compared to the global standards. Indicator definitions, they were sometimes based on countries' priorities and available data. We also found that the abortion-related indicators were only available in a few countries, and the data on this was often presented in absolute numbers rather than rates, which is the requirement, which is the global requirement, and which the definition. We also noticed that the information on post-abortion care indicators the information was largely unavailable in almost all the countries. Now, for the domain on violence against women indicator, RHI's tracking was found to be quite limited. The definitions were for most of the indicators where they were consistent with the global norms, and there were laws and regulation in place for access to sexual and reproductive health care and information and education across the Sierra region. And most of the data in this domain was actually captured by departments other than health, and therefore the data for data for many of the indicators could not be traced. This challenge we also kind of came across in the healthy aging domain. With respect to the other indicators, there was quite poor and limited data available for the healthy aging domain, and some of the information pertaining to the social security and regulatory framework, they might have been available and captured by non-health departments. So I just want to kind of highlight that we are building our capacity in more such score-related work, and we would be very much interested and willing to collaborate with some of you to develop such frameworks for your country's needs and priority areas. So this last project I want to showcase is the collaborative effort that we have undertaken with WHO India office to review the current situation of India with respect to the health equity. This work kind of attempts to create a national profile and framework based on the health equity analysis across the UHC tracers, indicators, and overall. This is a work that we are currently still undertaking. So we took a wide spectrum of indicators cutting across the 9 thematic areas, which is mentioned in the second row for analysis. And these areas were nutritional status of mother and children, maternal and child health, maternal and child mortality, reproductive health, prevalence and treatment of communicable and non-communicable diseases. We also looked at indicators related to WASH, which is water, sanitation and hygiene, and environmental health indicators. Then we also looked at indicators with respect to the health systems, primarily focusing on HRH and financial risk protection. Of course, we also looked at the dimensions of equity, and we captured data. We looked at data whether it is available in terms of age, mother's education, sex, caste, wealth, and also subnational units, which is district-wise data. So data for these indicators were drawn from 3 rounds of National Family Health Survey and 2 rounds of National Sample Survey Organization, NSSO. NFHS data was actually analyzed in 2 phases. In phase 1, we analyzed data, NFHS 3 and 4 data, to draw the trends related to various indicators like maternal mortality, MMR across states, and prevalence of child health indicators, wash, electricity, etc. In phase 2 of the analysis, we included the latest round of NFHS, which is NFHS 5, which is recently released. I'll just like to mention that this is still a work in progress, and we are currently analyzing and collating the key findings, and the results and the final findings will be available when the report is released. So thank you so much. That is it from my end.
There are some questions in the chat. So maybe Dr. Preeti would like to take them, and then Anjali.
Yes, I can answer the first couple of questions because I think they're all related. So I think Dr. Alvin had a question around SCORE, and what he was trying to ask is whether SCORE needs to be done by an external agency or can it be done by the government? It can be done by the government themselves. It can be done by an external agency. So we were the external agency that did it for the Southeast Asia region back in 2018. And there is going to be a second round of SCORE as well, probably coming up around 24, 25, which can also be done by external agencies, but that does not stop the government from doing it for themselves. They can do a self-assessment at any point of time because this is cross-sectional data. In fact, it will be helpful for the government if they did a self-assessment more frequently, because as we're inching closer to the 2030 date for SDGs, it's always better to know where we are with respect to the different indicators, especially for SDG 3 and the other related indicators. So I hope I've answered that question related to SCORE. I think just have a look at what was the other question. Meanwhile, Anjali, there was a question around, what is the difference between validated and approved? It was there in one of your slides. Would you like to take that? And in the meanwhile, I'll just have a look at the list of questions in the chat.
Sure. So I'll just exactly, I'll see the exact number. What is the number for the validated and approved ones? Yeah, so 99 countries validated and 34 countries approved. So by validated, if here the countries, they verified the data and they permitted the data used by WHO. So if I'll just elaborate on that, I had mentioned in my presentation that for the final findings, we had to take in the buy-in of the countries. For them to kind of review the SCORE, we had to take their endorsements to share with WHO headquarters towards the end of our exercise. So those countries, they reverted to us with their validation, with their sign-off, and they mentioned that they've reviewed the data and we can actually share that with the WHO headquarters for further analysis at their end. For the countries who just where it mentions 34 countries approved. So here it means that some of the data might not have been approved by the countries because the team might not have been able to establish contact with the respective country counterparts, or they might not have been able to share the final findings from their end for the final sign off. So the countries teams the team who would be collecting the data at their end and reviewing it, they would have taken the global databases, like especially for tracking some components in the intervention S, where joint external evaluations are done and SPA reports are generated by WHO. So those reports are available in the public domain. So the teams might have gathered the final data to be shared with WHO headquarters from the global reports or WHO validated documents. So I hope I've answered your question.
I'd just like to add to what Anjali said. So the SCORE exercise was basically carried out for every country as part of every country that is a member country of the WHO. maybe barring a few who refused to share their data, because a lot of this data is not available in the public domain. So the agencies, PHFI, for example, was one such agency. We had to go, it wasn't possible for us to visit each of the 11 countries. So we had to do it primarily through online meetings. And, we did a lot of deliberation with the WHO country offices of these 11 countries. So whatever data was available to us was the only source we had to sort of, use for our analysis. But it's possible that there is other data that may not have been available at that time for us to access, or the country was not comfortable in sharing that with us. So those kind of challenges we have faced at the time of SCORE. WHO Geneva has learned a lot of lessons during this entire SCORE assessment, not only from the Sierra region, but across all the regions where this exercise was undertaken. And so they're trying to use those and revise the SCORE assessment tool for the second round. In your respective countries also, hopefully there will be a SCORE round 2 coming up very soon. Yeah. I see that there is one more question around the challenges of implementation of RHIS. I think, I don't know how it is in the other Asian countries, but I'm assuming it's not very different from what we see in India. In India, we do have, as I said, a lot of data that's coming in from the routine health information systems. The primary problem, or rather couple of primary problems that that we've been observing over the years. One is the capacity of the people who are actually the owners of that data to analyze that data and then to use it, interpret it and use it for, say, health service delivery, or for controlling health problems, prevention of health problems, etc. So the capacity is one of the major issues. And the other is the quality of the data. So therefore the credibility, the validity, that becomes an issue. And because these are challenges that we've been facing since the past so many years, we have been relying heavily on our survey data. So our demographic and health survey data, our other surveys that we've been, time and again capturing data from. We've been relying heavily on those surveys for our health related data. So that was, I think, one of the questions. There are multiple, data systems. So I think there was one question around road accidents. Now, road accidents is not it's not a health indicator. It's not the purview of the health department to capture data on road accidents, but we do get in touch with, so we'll get in touch with the police, for example, the police department will get in touch with the law and order department and try and corroborate some of their data to come up with the answers for SDGs, the indicators which are part of the SDGs. So we also have our challenges. We've documented that in the assessments that we've done for India. Hopefully they'll be taken forward, and we'll see some improvements in the coming years. Thank you.
Yes, please go ahead.
No, I was just wanting to see if there are any more questions, but I don't see any new questions. Yeah.
Yes, I think there are no new questions in the chat box. Once again, thank you, Professor Zadpi, Dr. Preeti, and Ms. Anjali, for sharing your time and expertise to the AeHIN community, as well as to our AeHIN participants for joining us tonight. Before we end our webinar, I would like to call on our Executive Director, Mr. Jai Ganesh Udayasankaran, for the closing. Mr. Jai.
Thank you, Cha. And thank you, Professor Zodpe. Thank you, Negandhi and Anjali Sharma. It was very, very helpful to know about your work. Of course, we have connected earlier and then done some work, but I think going forward, there are opportunities to collaborate as well. And you also mentioned about the joint work together with HTC. So this is very helpful. I think since we are on top of the hour and then we have answered the questions, maybe we can connect further and then explore opportunities to work together. And thank you very much for this. This is very helpful. Thanks for joining us.
Thank you for giving us the opportunity. Thank you, AeHIN.
Thank you for this opportunity.
Thank you.